I will be discussing the 24-month follow-up for the Zilver PTX randomized controlled trial for the paclitaxel-eluting stent for femoral artery occlusive disease. We discussed this a bit yesterday, the 12-month results. Basically, I'll go over the background of the study, the design. We'll review the 12-month data, and then we'll give an extensive discussion of the 24-month data in terms of primary patency and safety. This is just a slide to show you the number of locations in the United States and outside that participated in the randomized controlled trial. A good large number of locations in order to enroll a good large number of patients. This is a picture that shows the stent, the two different stents that were used in the study. In the upper panel, we see the drug-coated stent. The interesting thing about the paclitaxel femoral artery stent is that the drug is basically sprayed onto the stent. There is no polymer which is used to attach the drug to the stent, which makes deployment, which makes the risk of thrombosis less than in the coronary arteries. Importantly as well, the Zilver stent is the mechanical support, the stent platform, and as we'll discuss, the durability of this stent is quite high with a very low fracture rate. The drug is eluted at the vessel only. There is no systemic levels of drug when using this stent. This main part of the study was a prospective randomized trial, multinational trial, overseen by the US FDA. There was a data safety monitoring board and the core lab, which performed all the analyses of the radiographic data. The core lab is independent of the company and independent of the investigator sites. And as you can see at the bottom, the inclusion and exclusion criteria: Rutherford ischemia category 2 or greater, vessel diameter 4 to 9 millimeters, and we used lesion lengths of less than or equal to 14 centimeters because we were limited to 2 stents per lesion. The results that were analyzed as the primary safety endpoint were 12-month event-free survival. And those safety events were worsening of ischemia, mortality, amputation, or the need to revascularize the target lesion. The primary effectiveness endpoint was patency as determined by duplex ultrasonography, where a peak systolic velocity ratio of greater than 2 was determined to be a significant restenosis. And if angiography were available, that were analyzed as well to determine the presence of restenosis. The follow-up of this study goes out to 5 years, where patency will be analyzed on an annual basis, and stent integrity will be analyzed at 3 and 5 years as well. It's important to discuss the way that the patients were enrolled, because this is a unique part of the study. And as I mentioned before, the US FDA mandated that Cook, when they designed the study, that they would compare their drug-coated stent to what the FDA felt was standard of care at the time, which was percutaneous transluminal angioplasty without stenting, which clearly was not the ideal situation when you're trying to compare a drug-coated stent to a bare metal stent, but this is what the FDA mandated. So that was the first group that was randomized. However, in the case of PTA, as we all know, when we do these procedures, there's a significant number of patients who have what we refer to as a failed PTA. And those patients were then re-randomized to receive either a bare metal stent or a drug-eluting stent, which allowed direct comparison of the bare stent to the drug-coated stent. Important to realize that failed PTA, every time we did a PTA in this study, we had to do an inflation for 2 minutes, and we had to submit the angiograms to the core lab for them to adjudicate the fact that yes, this indeed was a failed PTA. And approximately 97 to 98% of those that the clinician felt were failed PTA actually were based on the core lab analysis. So those patients were then, 120 patients had what were referred to as a failed PTA, and 118 were in the group of successful PTA. And I spent a lot of time discussing that because it's important when we look at the data. Those failed PTA, 59 had bare Zilver stent and 61 had the paclitaxel-coated stent. Demographics between the two groups were nearly identical. There was slightly higher hypertension in the Zilver PTX group, but otherwise the comorbidities were the same. The The lesion characteristics in this group were very similar, except that calcification was more severe in the drug-coated stent group as opposed to the PTA group. Yesterday, during my previous talk, we discussed the 12-month effectiveness of the Zilver PTX stent. And if you look at this slide, this is really a summary of the 12-month data prior to the 24-month data. If you look at all patients that underwent PTA, the primary patency at 12 months was only 32%. If they had a successful PTA, that was up to 64%. And those patients that got a drug-coated stent, their primary patency was 83%. And the patency of the drug-coated stents was statistically significantly superior to plain successful balloon angioplasty as well as failed balloon angioplasty. If we look at the patency in terms of the 12 months between bare metal stent and the drug-coated stent, again, we see a significant improvement in primary patency at 12 months with the use of paclitaxel on the stent, 90% versus 73%, with a p-value of less than 0.01. As we know, we really like to see the results of these kinds of interventions up to 2 years and even further. And I'm happy to report that after 2 years in follow-up, the results of the paclitaxel effect remain pretty impressive. So if we look at 187 lesions that received the Zilver PTX stent, the primary patency is 75% at 2 years and continues out to 30 months without a significant drop-off. If you look at the patients that underwent successful percutaneous angioplasty, their patency was only 58%, and the p-value was significant. If we look at that subgroup of patients who had failed PTA and underwent provisional stenting with either a bare metal stent or a drug-coated stent, we find that the effect is even more dramatic. 81% primary patency at 2 years and even out to 30 months versus 63% in the bare metal stent. And if you calculate this out, the restenosis rate is about 19% in the drug-coated group and 37% in the bare group, which suggests a reduction in significant restenosis of about 50%. In terms of the need to go and re-intervene on the lesion in question, at 24 months and out to 30 months, 90% of the patients who had a drug-coated stent did not require revascularization, whereas only 70% of the patients who had the bare metal stent were able to be without revascularization, with a 53% reduction in the need for revascularization, purely based on the effect of the paclitaxel. And I want to wrap up briefly by kind of showing you in real life what this means. So I'm going to show you two cases. First is a case of a patient who had the lesion shown in the left panel, was treated with a bare metal Zilver stent, and at day 244 represented with significant restenosis. And you can see the typical pattern of diffuse severe intimal hyperplasia and restenosis throughout the length of the stent. And the second case demonstrates what we've seen in the cases where we've used the drug-coated stent and they've had restenosis. So you can see on the left panel significant severe stenosis of the superficial femoral artery, and day 0 placement of a drug-coated Zilver stent with an excellent result. And at 12-month follow-up, they had duplex detected restenosis. This is one of those cases of restenosis that we talked about. But as you can see, it's a very focal, non-diffuse lesion, and it was easily treated with balloon angioplasty and recovered patency. So in conclusion, the importance of the 24-month data are that it really indicates that the beneficial effect that we saw for paclitaxel-coated Zilver stent at 12 months is sustained at 24 months and even out to 30 months. When we had to provisionally stent patients who had failed angioplasty, the effect was even more dramatic with a significantly higher patency versus bare metal stent. And we can conclude that paclitaxel coating of the stent reduces the 24-month restenosis rate as well as the need for target lesion revascularization by about 50%, leading to a conclusion that the use of the drug-coated stent in the superficial femoral artery leads to decreases in restenosis and better primary patency at 2 years and even out to 30 months. Thank you very much for your attention.
Próximo apresentador.